You know, dizziness has to be one of the most challenging presentations we see in clinical practice. But what if I told you that you could answer 80% of your diagnostic questions in just 5 minutes right at the bedside? Well, this explainer, which is based on the amazing guide from Australian Dizziness Clinics, is going to show you the exact framework to do just that.
All right, so this is the first part of our 5-part series, and today we're really laying the foundation. We're going to break down the core principles of the bedside clinical exam and show you how 5 super focused minutes can totally transform your diagnostic confidence.
And let's be really clear, this is not just some simple screening tool. A focused bedside examination, when you do it correctly, is an incredibly powerful diagnostic instrument. It can answer a staggering 80% of your questions about why your patient is dizzy.
And get this, the entire core protocol can be wrapped up in just 5 minutes. This means you can make urgent management decisions, you can localize the problem, and you can gauge how severe it is, often before you even think about ordering any imaging.
Okay, let's dive right in. We're going to cover why this exam is such a powerhouse. Then we'll get into the 3 main goals that should be framing all of your clinical thinking. After that, we'll walk through the logical sequence of the tests, talk about the one tool you absolutely can't skip, and finally, show you how it all fits together. So let's start with a really foundational truth. This examination is the clinical cornerstone of our field. I mean it. It's an irreplaceable skill that no piece of technology has ever managed to displace, and here's exactly why. It basically gives you a direct, real-time window into the vestibular system. You get to assess the vestibulo-ocular reflex, the VOR, that amazing reflex that keeps our vision stable when we move our heads, plus all the balance reflexes and critical brainstem cerebellar connections right there with the patient in front of you.
Now, before we get into the how, we have to establish the why. Every single test you're about to learn is aimed at answering one of 3 fundamental questions. This is what gives the whole exam its incredible diagnostic power.
First and foremost, and this is the big one, is the problem in the peripheral system, so the inner ear or its nerve, or is it a central issue coming from the brainstem or cerebellum? This is, without a doubt, the most critical question because it drives everything that comes next.
Second, is this an acute, sudden event, or is it a chronic, long-standing problem? The answer here tells you how urgent the situation is and whether you need to prioritize something like the HINTS exam to rule out a stroke. And third, are we dealing with a mechanical problem, like the displaced crystals of BPPV, which we can often fix in minutes, or are we looking at an ongoing functional loss that's going to need a full rehabilitation program?
And this slide just brilliantly illustrates that critical distinction. See, peripheral signs, like a nystagmus that always beats in the same direction, they tend to follow predictable patterns. But central signs, like nystagmus that changes direction or goes up and down, those are huge red flags that demand immediate attention. Okay, now for the how. Having a structured, systematic approach here is absolutely essential. It stops you from missing key signs, and it makes sure your exam is both efficient and something you can repeat reliably. The sequence is always the same: static, then dynamic, then positional. And this logical flow, from least to most provocative, is so important. It lets you spot potential brainstem or cerebellar problems first. And, critically, it stops you from accidentally tiring out a positional nystagmus, which could completely mask a BPV diagnosis.
Now here's the crazy part. You can perform all of these tests perfectly. You can do them in the right order, and you can still miss the most important signs. So, how does that happen? It's a pretty shocking statistic, isn't it? Studies show that up to 70% of spontaneous peripheral nystagmus is just completely missed in a standard examination. And the reason for this is a physiological phenomenon called visual fixation suppression.
You see, when a patient can fix their gaze on something, their brain can actually suppress the nystagmus, pretty much hiding it from you. And this is exactly where Frenzel goggles become non-negotiable. Their powerful lenses magnify the eyes and, most importantly, they eliminate fixation. They literally make the invisible visible.
This clinical pearl from the guide is just vital. You have to examine with fixation removed first using the goggles. Only then do you re-examine in room light. You see, it's the change, or the lack of change, between those 2 conditions that is itself a key diagnostic sign. It's a huge clue for differentiating peripheral from central problems. So let's bring all of this together. We've talked about the power, the goals, the sequence, and the essential tool. Here is the framework that you can take and apply immediately in your practice.
Just remember these 3 pillars. First, a logical sequence, static to dynamic to positional. Second, Frenzel goggles are absolutely mandatory, they're not optional. And third, every single thing you do is framed by those 3 guiding questions. This, right here, is the foundation for a confident and accurate vestibular diagnosis.
Okay, so now that you have the foundational framework, we can move on to mastering the interpretation of nystagmus itself. In the next part of this series, we're going to dive deep into Frenzel technique and the specific features that will help you reliably tell the difference between peripheral and central disease.
Thank you so much for joining us. To get access to the full clinical reference guide and a whole bunch of other resources for clinicians and patients, please visit our website. And hey, if you found this useful, please subscribe so you don't miss the rest of this essential series.